Jerry had this question. How long can patients stay on azacitidine and venetoclax before relapse or toxicities force them to abandon treatment?
Yeah, so this is a good question. I would say azacitidine and venetoclax just got FDA approved, just shy of 5 years now, and it's totally changed our treatment paradigm in many great ways. It was initially approved for patients that could not get intensive chemotherapies or were above 75. We call these our older patients that are more vulnerable. And we demonstrated that compared to azacitidine alone, it was given with placebo. We saw that the combination of azacitidine and venetoclax not only was safe, well tolerated, it led to 2.5 times higher complete remission rates and impressively longer survival. That's all we care about. Patients are living longer. So one of the things that we are appreciating in 2023 now that we have more patients on azacitidine and venetoclax, is that we have many patients that are long-term responders. So in the original clinical trial, we've been reported and we just submitted the update for the long-term follow-up that we presented at the American Society of Hematology meeting in 2022 in December. We presented a long-term follow-up data that shows that responses can be durable and even as long as 2 years or 3 years in some patients. The average amount of time that patients are on therapy is somewhere between 1.5 to 2 years. But not every patient performs like an average patient. We have some that respond for less time, and we have some that respond for a longer time. So I definitely have a few patients that have been on combination therapy, and we've gotten to year 3, then 4, and one that got to, two that got to year 5. And that was using the original indication of older than 75, no intensive chemotherapy. Most of those patients in the original trial that led to the approval were not transplant candidates. But once those drugs got approved, more patients that were older started getting this therapy. And so the durability of this treatment might be longer for people that don't have competing health problems and for specific mutation subtypes. There's a couple of mutation subtypes. They include like IDH2 and NPM1, where we've seen some extreme long-term responders. And then there's others that it's much shorter. So I would say it's very individual. In terms of toxicities, in general, the regimen is very well tolerated. And if it's not, often it's because there should be supportive care, prophylaxis, and adjustments to the dosing strategy, which has been well published. Sometimes if you have a treating oncologist that is less familiar, they won't know the nuances of how to adjust the doses. So I would ask your local oncologist to reach out to anybody that was a part of the original trials. Often a lot of us are very responsive to helping out our colleagues to help patients to stay on treatment. But at the end of the day, if a patient loses response or has a bad toxicity that makes it very difficult, we have to move on to another therapy. So I would say the majority of patients that relapse the first time will relapse the second time unless we can successfully bridge them to a transplantation.